course, I want to start out saying that I have no conflict of interest, actual or potential, in the presentation. I do want to point out that I'll be talking about some supplements today, and just to make sure everyone knows that supplements aren't regulated by the FDA or evaluated. So it's more anecdotal evidence supporting the use of supplements, and we want to just use critical caution when we're looking at that with our patients. The information that I'm going to share today is a combination of my understanding of the research that I've been evaluating, as well as my experience working with patients. So like many of you, I left the education world and entered the workforce full of facts and evidence-based research and ready to apply it. And once I applied that to the human model, it didn't translate quite so clearly. So if anything, my takeaway that I want for you today is that it's how we treat people more than what we know, and what we know comes secondary to that. It's definitely something I've learned through the process of working with patients over the last 8 years. Here are our learning objectives. Ultimately, the reason I was requested to come speak. We want to look at some of that evidence-based data regarding food, supplements, things to encourage or maybe avoid or limit for managing our chronic pain. And then we really want to talk about how to do it, how to have these conversations with our patients about nutrition. I do want to make a note that on your zip drive or in the back of the room, there's a handout that you are welcome to share with patients that is going to cover a lot of what we're going to discuss today, so that you can be more equipped to have these conversations. Let's set the stage. Here's what we're going to talk about ultimately. How to talk about nutrition, when to talk about nutrition or when not to. Specifically, I want to touch on eating disorders and weight bias in the healthcare environment. Once we're ready to talk about it, the how-to, understanding the psychology of how we can enact nutrition changes with our patients, what those changes should look like, and then a few tidbits about interactions or cautions with different supplements and their medications. So first off, understanding the patient experience. Let's look at disordered eating and weight bias. In general, in our patient population, we want to screen for eating disorders, use caution or at least sensitivity with weight checks, regardless of the size of our patient. This might involve recognizing our own weight bias, whether it's implicit or explicit, and then using caution with any recommendations for weight loss. Screening for eating disorders is incredibly important. 30 million people in America, men and women, are currently diagnosed with an eating disorder. And diagnosed is in all bold there for you to know that there are a lot more folks who are experiencing eating disorders or disordered eating that do not carry the diagnosis, so we aren't aware of that. Unfortunately, the DSM criteria for the diagnosis of anorexia includes being underweight. So I see a lot of people who do not carry the diagnosis, however, have all of the other symptoms of anorexia nervosa, and they're not diagnosed just because they're at a higher body weight. It's really important for us as providers to start to screen for this and be aware of it so that we're not perpetuating the problem, if at all possible. And of those that we do know are diagnosed, every 62 minutes someone is passing away as a direct result of an eating disorder. So it is a serious condition that we could bear witness to. How do we do that? Maybe we can ask some questions. I included on my upfront intake form asking my patients if they have a history of an eating disorder. And that's really something that all of us could include regardless of our practice or specialty. Those questions might look like just asking if a person has ever been diagnosed with an eating disorder, or maybe they have a hunch that they do have some disordered behaviors. Or asking if their weight or their relationship with food is a source of struggle or suffering. Okay, a couple simple questions. If the answer to either of those is yes, then we want to engage in a different way. We need to recognize that much like substance abuse, eating disorders aren't one that we heal from and we're done with. We may be in remission, we may be in recovery. However, the chance of relapse is very real and very common. So if the answers are yes, ask ourselves, do we need to weigh this patient? Of course, understanding that for meaningful use or dosage of certain medications, it's important for us to have a weight on our patient. But if it's not absolutely necessary, maybe we skip it. And of course, if the answers to those questions are yes, please don't make nutrition recommendations. Luckily, there are ample dietitians and other healthcare providers who specialize in eating disorders that you can then refer to so that those conversations can still happen, but in a way that's more supportive of the patient. Okay, so when in doubt, refer, refer, refer. Not refer, refer. Different, fewer E's. So if I must check a weight on a patient, please consider a blind weight. Blind weight meaning that the patient is backwards on the scale facing away. And I might explain, I do need this number for your medication dosage or meaningful use with the insurance, but it's not something that I want to be part of our interaction today. You'll find how many patients are pleasantly surprised to have that kind of encounter with you. And then just acknowledging that even the most basic nutrition recommendations can be triggering for someone. So if my patient hasn't raised any red flags about eating disorders and I'm ready to proceed, I'm still going to be careful with my weight checks. And then recognizing weight bias. This is where things get a little bit squirmy for us. I acknowledge that, myself included. So pain and weight have a funny relationship, and it can often look like chicken or the egg. A lot of times we have patients who are injured or something happens post-op pain where they aren't able to be as physically active, which can result in weight gain. If that patient presents to the provider's office and the primary treatment that is recommended is weight loss, we're caught in a cycle, but my pain caused my weight gain. You get it, okay? So we really just want to have the conversation with the patient to dig a little bit deeper into what's actually going on with them. We know that through equitable health care, providing patients the access to the same treatments regardless of their body size helps them heal no matter what. So patients in smaller bodies or larger bodies are going to benefit from physical therapy, right? And we can achieve that before weight loss could actually be achieved. It actually gets us on our way to healing a little bit sooner. Some providers who specialize in eating disorders also have recognized that the eating disorder behaviors can be related to chronic pain. It's a mechanism for achieving control when I don't feel control in my body otherwise. So that's another way that we could get caught in this cycle if we get that patient trying to focus on weight loss again and they're feeling like they're out of control with their bodies. So before we ever start to talk about food, we really need to have some sensitivity to these possible triggers and issues with our clientele. If you're curious about your weight bias, there are some tests out there. Harvard actually has some implicit dissociation tests for all sorts of bias. And for physicians in particular, there are free continuing ed trainings through the University of Connecticut. You can go to ruddcentercme.org, and there are trainings and tests for addressing your weight bias. This isn't meant to put any of you on the spot if you have been treating your patients differently based on their body size. This is a way for us to start providing that better, safer care to all of our patients. And it's looking at everything from the furniture in our waiting room to the size of our gowns and blood pressure cuffs, and then down to our conversations with patients. Something we can all benefit from. The last thing I want to say before I get off my soapbox about weight bias is that it doesn't just negatively impact people who live in larger bodies. Weight bias impacts everyone. Sometimes people who are living in smaller bodies but have serious conditions are not diagnosed or treatment is delayed, because when we're looking at their size alone, they're given a clear bill of health. So if we can really take a look at behaviors, metabolic measures, the whole picture with a patient regardless of their body size, we're more likely to provide that equitable health care across the board and help, not harm. Okay, so my patient doesn't have an eating disorder. I've already addressed my weight bias and created this safe environment for them. Let's start talking about change. You now have the go-ahead to talk about nourishment with them. Here's how to do it. Let's use a little bit of psychology of change with these folks to really encourage self-direction and self-efficacy with them. They're more likely to comply and continue to comply in these ways. We want to focus on what to eat rather than what not to eat. And I bet all of you in this room can really relate to that. As soon as you've said you're never going to eat chocolate cake again, the chocolate cake is up on a pedestal with sunbeams cascading down on it and angels are singing, right? So that doesn't work. But what does work is focusing on what to eat, and then we can have a natural substitution effect of sorts, where we're filling up on these foods that are nourishing our bodies. We may naturally end up eating a little bit less of those things that might be leading to some inflammation or pain in our bodies. Either way, the benefits are experienced, right? Even if I continue to eat some pro-inflammatory foods, I still reap the benefits of eating anti-inflammatory foods. The other piece of this that really helps us to encourage that efficacy with our patients and the compliance is the way that we offer and provide education. This is the hard part. We need to ask permission, and if the answer is no, we have to accept that. But ultimately, it's easier for you, less work, not wasting your breath, but also the patient is more engaged with those conversations if they've accepted this information. An example of that would be if you were to use a handout on nutrition or any health behaviors. I might say, you know, I have a handout on that. Would you like to take a look at it? Or is this something you want to explore today? Fingers crossed that they say yes. Then we've got permission to proceed and explore it with them. Let's take a look at this. Which bits of information are really speaking to you? Fantastic. Let's work on those ones, right? Leave out the rest. And then you're invited to take this home with you if you would like today. If they leave it, even though our egos are a little bit hurt, again, the patient has gotten what they needed out of that interaction, or you've saved some of your hard work. This is a motivational interviewing technique, and some of you might be familiar with that, and it does make our interactions with our patients more like a dance and less like a wrestling match, right? Where really we just want to get them to do all the things we want them to do, but that's not working. So if we can dance with our patients and get them to focus on what to add into their lifestyle rather than what to subtract, we're all going to feel more successful in the end. Let's talk about what, shall we? That's why we're here. When we talk about pain, turns out it's pretty broad. Non-cancer pain opens up room for a lot of different conditions, whether it's neuralgias, neuropathy, complex regional pain, arthritis, myalgias, so much to it. So today we're really going to keep things broad, and in general, an anti-inflammatory diet can benefit most of these conditions. So we'll take a closer look at that. There are some foods and supplements that impact specific types of pain or may mimic certain drugs. But in general, like I said, that anti-inflammatory diet can benefit most of these conditions. Here's what to eat. Plants, probably not a surprise to any of you. Plants are really going to provide most of our anti-inflammatory properties, high fiber, feed our gut microbiome, so much benefit from a plant-rich diet. We'll look at each of those in detail in a second. Some supplements to consider are omega-3, vitamin D, magnesium, and B vitamins, and we'll touch on probiotics a bit as well. Fruits and veggies, high in fiber, who knew? Turns out that the fiber and the variety in our fruit and vegetable intakes are actually what feeds our gut microbiome the most, even more than taking a probiotic supplement. These fruits and vegetables are prebiotics, which means food for the bacteria. So a diet high in fruits, vegetables, plants in general is also high in fiber and food for our gut bacteria. You might have heard Taste the Rainbow. Skittles stole that from fruits and vegetables. So we really do want to try to get all of that variety into our diet so that we can feed the variety of bacteria, not just a few. Here we're looking at antioxidant benefits from the different colors of plants. Some anecdotal evidence does limit nightshades in arthritis. That might be something you're already familiar with. So that's our potatoes, eggplants, peppers, tomatoes, and tobacco, which hopefully no one's eating tobacco, but it does become significant when we look at organic versus traditionally harvested produce. So which ones are the best to eat? The answer is yes. Which ones do you like? Might be the question that I would counter that with, right? And then, of course, increasing variety in general with all of our produce intakes. When talking with people about their produce intakes, I always like to look at things in a continuum, right? We're considering so many factors with our patients: their socioeconomic or financial status, their current knowledge, their access to foods, their cooking know-how. There's a lot to it. So some folks might be living on canned vegetables and fruits. I'm going to say that's better than none, right? But some of us might have a garden or have access to the farmer's market or a larger variety of different types of produce based on their status. So we really want to meet people where they're at with that and know that they're getting the benefits no matter what, for the most part. I like to look at this like a continuum. So nutrient density is ultimately based on how much time that fruit spends on the plant. Once it's picked, it starts losing nutrients immediately, specifically the water-soluble vitamins, B vitamins, and vitamin C. And the composition of that plant is going to start to change from starchy to more simple sugars as it's off the plant. So if I can grow it in my backyard, the most nutrient dense. I walk out, I pick it, I wash it, I eat it. Delish, right? Not all of us have access to that, of course, but if we do, that's optimal. Farmer's market is a close second. So here in Bend, we're pretty fortunate that when we have farmer's market, nothing's traveling more than 180 miles. So that produce is picked either day of or day before and then brought to market. Still really nutrient dense, highest in fiber, B vitamins, and vitamin C, all of which are antioxidants. Next is frozen. Frozen produce is picked, washed, frozen same day. And those water-soluble nutrients are maintained in that setting. So it's actually higher than what's at the grocery store. Please don't tell Albertsons that. I don't want them to stop letting me come do grocery store tours there. And again, then after that, we would have canned. So backing up really quickly, the reason that the produce in our grocery store is less nutrient dense is time off the plant. Might be grown in Mexico, put on a truck up to Salem, makes its way here, then sits in the store under UV lights and a nice shower of water every few hours, all of which are depleting the nutrients. Okay. The bottom line, no matter what, please eat them, right? Even if we're eating nothing but canned produce, because that's where we're at, either financially or demographically or geographically, the bottom line is to eat it, and the benefits outweigh the risks. Just circling back to our B and C vitamins, they're involved in energy metabolism, regulation, nerve function, some pain implications there. So what about organic? There's the bottom line. You're probably going to know where I'm going with that. And even the Environmental Working Group, who is so pro-organic all the way, They're the ones that provide our Dirty Dozen and Clean 15 lists every year. They will acknowledge that the benefits of eating even traditionally grown and harvested produce outweigh the risks of not eating produce at all. Okay, so let's look at this again on a continuum of cost. If I'm on a SNAP budget or just don't have a lot of expendable income for food, I probably don't want to buy a lot of organic. I just want you to get it in your mouth one way or the other, right? If I land somewhere in the middle, maybe I'll choose to purchase organic produce off of that Dirty Dozen list. And that is updated each spring with the environmental working group, so it's not a list that you can print once and keep forever. We can have copies of that in our waiting room for patients to grab if they're interested in looking at that. If something's on the Clean 15 list, it means it's naturally pretty low in pesticide residues, so save your money. Buy that traditionally grown and harvested. Or if I win the lottery, have a whole bunch of money and I just don't know what to do with it, I can definitely go all organic all the time. That's not going to hurt, that's for sure. Okay? So this is a conversation to be having on a case-by-case basis and really see where people are landing. One of the things that I hear so much in my patient interactions is, yes, I eat pizza, but I buy the organic one, right? So sure, that organic packaged food is going to have less preservatives, less additives, probably a little bit better choice, but I'm still pushing that when we're talking about this, it's about our produce. Turns out that anthocyanins, our deep reds and purples, are really the power players when it comes to inflammation. So these are some of the foods that we could be promoting across the board to our chronic pain patients. The anti-inflammatory anthocyanin is highest in blueberries, tart cherries, and pomegranate. So those are foods that we can encourage. If our patients are watching their blood sugars, I'm going to encourage them first to eat it rather than drink it, and try to pair it with a protein or a healthy fat so that it slows that spike in my blood sugars a bit. Some research at the University of Michigan looked specifically at tart cherries and tart cherry juice and says that it has the highest concentrations of anthocyanins 1 and 2. So those ones work on the enzymes COX1 and COX2, which are the same as what our NSAIDs are attacking or addressing. Aspirin, ibuprofen, acetaminophen, all of those are working to block those enzymes. Tart cherry juice does the same thing. This is going to decrease oxidative stress and potentially be a way to use food to decrease our pain levels on a daily basis. For the tart cherry juice, 4 ounces is hopefully a serving. Definitely don't need more than that. It's a half a cup, or maybe up to a cup of the actual fruit. And then with pomegranates, it would be 8 ounces of the juice or a 1/4 cup of the seeds. I should back up a little bit and say that I hope I don't ruin anybody's lunch today. Hopefully they're going to serve up a whole bunch of anti-inflammatory foods. So we've got a couple hot topic items with herbs and spices. Turmeric is really making a comeback or coming to our forefront of our attention as an anti-inflammatory spice. And I want to talk about how we use it and some contraindications or cautions for it. So first off, in order to get the anti-inflammatory benefits of turmeric, we need 15 tablespoons in a day. That's almost a cup. That doesn't work, right? Even in cultures that eat a lot of curry, they aren't eating that much on a daily basis. There might be the buildup, but it's too much to eat. So this is one situation where I would recommend the supplement instead of the food. And typically I am the opposite. I have a foods first practice. So 15 tablespoons of the turmeric provides 2 grams of curcumin, and that's the really active component that's decreasing our inflammation. That amount is equal to 800 milligrams of ibuprofen. That can be really significant in addressing our pain, especially if someone can't tolerate ibuprofen or other pain relieving medications. So we're going to recommend a supplement instead. And I know the print on this one is a little bit small, but this shows that one capsule provides 750 milligrams of mostly curcumin. So we would need about 3 pills a day to equal that 2-gram amount. These supplements include pepperine, which is a component of black pepper. It's an irritant to your stomach, which helps you to absorb it. But we can see then if we have someone that already has a leaky gut or a sensitive stomach, this might be an irritant to them. There are many medication interactions with this supplement and food, so we're going to visit that in a minute. Turmeric sister is ginger, actually come from a very similar plant. And it has some anti-inflammatory benefits that are really similar to NSAIDs. A 1/4 teaspoon of dried ground ginger can have the same effects as the use of NSAIDs throughout the day, up to 800 milligrams again. That's only 2 tablespoons of fresh ginger, much easier to eat than a whole cup of turmeric, right? A little bit more realistic there. Let's talk more about plants. So minimally processed grains are involved in an anti-inflammatory diet, and they're going to have that substitution effect for some of our processed foods, but they're also the highest in fiber, high in inulin, really feeding our good, healthy gut bacteria. All of the ones demonstrated here, excluding barley, are gluten-free, so they're also suitable for a gluten-free diet or use on an elimination diet. The only reason I recommended organic quinoa is that it often is less bitter than traditional quinoa, so our patients might more readily accept it. And it does need to be rinsed before we use it, otherwise it remains bitter. It's a smart plant that has the will to survive, so it's coated in a kind of a soap, a saponin that keeps birds and other critters at bay. All of these grains are cooked exactly the same as rice, a 2-to-1 ratio of water to grain, so they're pretty easy to use once we start playing around with them. Wild rice, of course, is a grass, not a grain, but we can use it in the same way in our meals. Legumes or beans are used either in place of grains or in addition to grains. They're an awesome source of protein, fiber, inulin, which feeds our gut bacteria, and ALA omega-3 fatty acids. So if we're filling up on these, we're definitely going to experience the substitution effect and not be as hungry for that slice of organic pizza. When we talk about omega-3, we might be moving in the direction of supplement being better than food. There are different forms of the omega-3 fatty acids. ALA needs to be converted in our body to EPA and DHA, and it's not done very well. So we need to eat a lot of plants in order to convert to the same amount of EPA and DHA that we could get from a serving of fish. There's some stuff going on with our fish, and everybody has different opinions on that, so that is why I think that an algae or krill oil supplement might be beneficial rather than making blanket recommendations for more fish consumption. But again, that depends on where our patients are with their beliefs about the food system in that way. Algae and krill are the little guys at the bottom of the sea. They're going to be naturally lower in mercury. Our mercury content gets bigger as our fish get bigger because they're eating everything else that's been consuming the mercury. So that is one reason why they're recommended more than other fish oil supplements. We want to warn our patients that they could be a little gassy as they're adjusting to this, but hang in there. Walnuts, flaxseed oil, and those greens that we see up there are all sources of the ALA omega-3 fatty acids. But again, we need to eat a lot of them in order to be converted. Next supplement, vitamin D. This one we kind of know about, right? but the deficiencies remain really frequent, really common. Despite the fact that we all seem to understand how important vitamin D is, our population remains low in the nutrient. We've got muscle weakness is a common outcome of low vitamin D levels, so that could be something that our chronic pain patients are experiencing. When vitamin D levels are low, I recommend that we don't mess around. A mega dose may be useful to get us up to the level, and then a lower dose supplement to maintain. A lot of times I see patients in the clinic who have low vitamin D levels but are taking 2,000 IUs a day, and that's not going to be enough to build us back up to where we need to be. Vitamin D does have risk of toxicity, so those mega doses have to be supervised, have to be used with caution, as does supplementation used in the home. Vitamin D3 is what's most easily absorbed and utilized, but D2 still does the job. A lot of times people ask those questions and the answer is yes. The upper tolerable limit of vitamin D, so the amount that can be toxic at higher levels, is 6,000 international units a day, and that's an adult dose. For kids, it is lower than that. But we can safely take up to 6,000 units, international units of D a day, and have some benefits. We can also eat it. We do see there that the primary sources of vitamin D are again from fish, and that it takes quite a bit to add up to the amounts that we need. B12 is correlated to poor nerve function and ataxia. This is one that we're going to see in our patient population who abuse alcohol, those who have had a history of parasitic gut infections or leaky gut syndrome. So this is something worth testing and can either be addressed through intramuscular injections, the diet, or supplementation. Again, seafood, the highest sources of vitamin B12. As we get a little bit older, intrinsic factor in our gut is declining, so our ability to absorb the Bs is also declining. So as we're adults and above, a supplement can be more beneficial than eating the foods. Magnesium deficiency, also correlated to poor nerve and muscle function. And I don't have the percentage here, but of patients with fibromyalgia, would say that a significant amount of them demonstrate magnesium deficiency. The food sources for this are primarily going to be bran, brown rice, spinach, almonds, and then again, supplementation is beneficial. The amount that's recommended for magnesium through food is 400 micrograms per day, and the upper limit for supplementation is 350, so we do want to be careful with magnesium supplements. I'm going to take a look at some medication interactions and food precautions. Now we're all vegetarians, right? Plant-based diet, tons of grains, beans, fish, or supplements. Maybe eating some ginger. Let's look at meds. So methotrexate, often used in rheumatoid arthritis and other inflammatory conditions, depletes our folate levels, which also nearly doubles the side effects that we get from the administration of methotrexate. We absolutely need a folate supplement in our patients who are receiving methotrexate. Up to a 5 milligram dose can be provided the day after methotrexate is delivered, and not only decreases the side effects, but also maintains the baseline levels of folic acid. Those turmeric contraindications that I told you about, important to know that those who are on anticoagulant drugs or antiplatelet drugs should not take turmeric. It mimics the actions of those drugs and can result in bleeding that we don't want. Turmeric also stimulates gallbladder function. So in a healthy, otherwise healthy body with a healthy gallbladder, healthy kidneys, it can have protective qualities. But if I already have stones or active kidney or gallbladder disease, it can make those conditions worse. So when in doubt, we want to skip it. There can be an increase of calcium oxalate stones in the kidneys with this excess turmeric supplementation as well. Here's what not to eat, what you really want to know about. My caution is please don't tell your patients this unless you have thoroughly screened them and we know that eating disorders, weight concerns, that we aren't going to be triggering them in any way. Instead, if we can focus on those foods to encourage the consumption of these foods will hopefully decline. So an anti-inflammatory diet is going to eliminate all processed foods. It's going to eliminate fried foods, which are increasing our exposure to free radicals, which are inflammatory. It's going to be much lower in meats, specifically no processed meats. Low to no dairy, low to no refined grains, specifically gluten. Low to no added sugars, no artificial sweeteners, and elimination of alcohol. All the good stuff, right? Hopefully no one has tomatoes to throw at me. So when we look at our refined grains and specifically gluten, an elimination trial can be beneficial, and if it's not improving someone's symptoms, we can bring it back. We're kind of in this spot where on the one hand we can be gluten-free and still have access to a lot more variety of foods thanks to celiac and gluten intolerance, but it's a lot of processed foods. It's got a lot of other stuff added to it. So ideally we can just sub out gluten and wheat containing foods for those other grains that we previously looked at, the millet, the teff, amaranth, quinoa, etc. With added sugars in general, it's too much is too much. For most of our chronic pain patients, when we're really going to see the sugar impacting their pain levels, it's if they have diabetes or poorly controlled diabetes, when neuropathy and other problems start to come on board. With artificial sweeteners, there's unfortunately some controversy about it, but I will say that most of the research looking at the safety of artificial sweeteners is supported by the Calorie Control Council. And if we look who sits on the board of the Calorie Control Council, it's the artificial sweetener companies. So even though sugar has gotten a bad rap, I know exactly what my body does with it. I know that it's fuel, I know that I can burn it, right? And I know that I just don't want to go over on my consumption of it. Artificial sweeteners, we're just not so sure because of some of that conflict of interest that's involved in that research. Alcohol has anti-inflammatory benefits, right? We remember the resveratrol in red wine and just the general decrease in cardiovascular risk from consumption of alcohol, 1 drink a day. But even 1 drink a day increases our liver enzymes and the inflammation that our body's experiencing. So if we could use that tart cherry juice or the pomegranates instead to get our dose of resveratrol, we know that that's going to be more beneficial. And again, don't tell your patients this. So I have a couple more things I want to talk about, but let's check on time. Am I okay? Okay.
It's 12:16.
Perfect, thank you. What about leaky gut? Oops, ignore that. So leaky gut is the other thing that's coming up in conversation a lot of late. Our gut is a single layer of cells, and those tight junctions, when they're separated, they allow things to pass through the gut barrier that are not supposed to. And gluten is one of those that passes through, so that is why gluten is always coming up in conversation of late. When substrates that aren't meant to pass through to the bloodstream, it leads to inflammation systemically, which can definitely have a role in chronic pain, and specifically attacking our joints, and in the worst case scenario, probiotics can pass through that barrier and lead to sepsis. Or those bacteria are just showing up other places in the body, hanging out in the liver, causing problems. So leaky gut doesn't have a ton of research around it. It's new. It's not something we're learning about in our medical training, but we're starting to explore it and understand it a little bit better. The primary things that are leading to leaky gut is NSAID use, so a lot of our patients would experience that, alcohol use, a history of antibiotic use, stress. So right now I am probably experiencing a leaky gut, but I'm confident that it's going to resolve once I'm done talking to all of you. Avoiding gluten can help with that because, again, gluten and gliadin are some of the molecules that like to pass through those tight junctions once they're opened up. But immediately we can work on getting alcohol out of the system, decreasing our need for NSAIDs, lowering our stress levels. Glutamine and zinc can help strengthen those tight junctions, shrink them back up. So those can be supplements that are beneficial to our folks who are experiencing leaky gut. The way to know if we have it is a lactulose mannitol test, which isn't easy to access. It's not something I can just zip down to my local lab and receive. Maybe some of our naturopathic physicians have access to that test, or it's something that can be ordered. Right now it's primarily used in the research setting. We can make some assumptions that my patients might be having leaky gut if they've got celiac, type 1 diabetes, inflammatory bowel diseases, or for a long time have been using NSAIDs or alcohol. We can make those assumptions. And so getting rid of the alcohol, decreasing the gluten, getting off the NSAIDs, all of that can be beneficial with that. Considering that, paired with the anti-inflammatory diet and that little bit of supplementation, can be beneficial whether we're experiencing chronic pain or not. Once my gut is healed, then it's safe to add that probiotic back in, and especially if I'm eating that varied plant diet, that's going to give it something to feed on. The varied plant diet is more effective at improving our gut microbiome, or has more of an impact than age, weight, antibiotics, stress, tobacco use. More than all of it, our gut microbiome just wants some good food to work on, don't we all? So again, probiotics should not be a blanket recommendation. We can always start with foods: sauerkraut, kimchi, miso, kefir, yogurt, a little bit of kombucha. All of those are going to help contribute probiotics to our gut, and then a supplement beyond that. There's a really nice website, usprobioticguide.com, that is actually created for medical professionals. Again, it's usprobioticguide.com, where we can plug in what population we're working with and what their symptoms are, and it will give us recommendations on the best probiotic supplement to choose. Thank you. I'm happy to answer questions. I know that's a lot.
Thank you.
Yeah.
Okay. Yes.
Mm-hmm.
What are your thoughts on stevia and resveratrol supplements?
Great question. Let me think. I was just reading about resveratrol supplements last night, because that's what we do, right? Sit up all night and read. Poorly absorbed compared to food sources was the main thing that I can recall on that. But if we're not able to tolerate tart cherries, pomegranate, some of those juices, then I would probably say it's a safe bet to try. In general, with our supplements, since they aren't regulated or evaluated, let's just encourage our patients to do their research and try to find companies with the best ratings, with Better Business Bureau, the best customer reviews, things like that. With stevia, it depends. If you can grow a stevia plant on your back porch and go pinch a leaf and muddle it in your mint, fantastic. Works great, super sweet. We're also going to get a little bit of antioxidant benefits and vitamin C from it, so it sounds like a win. Unfortunately, what our industrial food complex has done is taken that complex plant and extracted one ingredient, riboside A, and crystallized that for what we now buy in a packet and put in our food. It's not shown to be harmful, but it's still pretty new, so there's not a lot of research. And I just don't want to underestimate the power of plants and how complex that environment is that's in the whole plant. So much like how an apple has arsenic in it, right? Well, I'm not going to just eat arsenic. I'm going to eat the whole apple and hopefully not the seeds. The complex of the whole plant is protective, whereas that one compound is not. So with stevia, I encourage people to use the whole leaf whenever possible, or use a little bit of sugar, more so local organic honey, and then burn it off. Thanks for asking that.
Thank you. I would always prefer food over supplements, but I think a point of clarification might be helpful, and that is that just because the FDA has not evaluated a supplement does not mean it hasn't been subject to empirical study. So I would encourage people to go to PubMed and look up the studies themselves. And of course, they vary from supplement to supplement. They vary in terms of evidence quality, but there is a ton of research out there. And in terms of prescribing them, I would encourage people to go to, if you're a clinician, to use a distributor like Emerson Ecologics. They do third-party verification of companies. They actually go and they visit the manufacturers, they test the supplements for contaminants, potency, and so on. So it's no guarantee, but it's at least a place you can go.
Yeah, thanks for that. And not a question, obviously. But just to clarify about the regulation, it's brand by brand. So if I want to open a supplement company, it might be for magnesium, and we've already seen the research on that, but I'm not guaranteed that what I'm selling you is magnesium. So using that company like Emerson or another one that does have the backing behind it is what's important. Yeah, hi.
Thank you. I have two questions. One is, do you know what levels of EPA and DHA are effective in fish oil supplements?
Good question. In general, we want about 2 grams of DHA and EPA a day for the anti-inflammatory benefits. Each supplement is going to have different amounts. So if we were getting it from food, I'm looking at 2 tablespoons of flax to be the equivalent to 2 grams. But with supplements, we just want to read that label and know that 2 grams is what we're looking for.
My other question is, do you think the benefits of the blueberries on that cheesecake back there outweigh the adverse effects of the added sugar?
Great question. Right. Well, here's what I want to say about that. I titled this talk Nourishment and Pain, not Nutrition and Pain. Nutritionism can really get us into trouble, and when we broaden the lens and look at nourishment, it includes satisfaction, it includes social connections, it's nourishing so much more than just our vitamin and mineral needs. So better than if it didn't have the blueberries. How's that?
Any other questions?
Is there any, taking this kind of in the whole, if you're to encourage people that are in chronic pain to follow something like a diet, specific dietary recommendations to help decrease their pain levels, are there any studies to look at like following a diet like this to just a regular diet and what kind of pain difference that makes? Like, am I decreasing 2 points on a pain scale? Like, is there anything like that?
Good question. Not that I've seen. Maybe some of the naturopaths in the room who use anti-inflammatory diets might be able to answer that. But I will say that the elimination diets and manipulating specific nutrients is really on a case-by-case basis too. What might give you amazing benefits might not make a difference for the person next to you. And it's for so many reasons, including that gut microbiome, how different you are in your bacterial makeup than the person next to you. So we know that elimination of pro-inflammatory foods doesn't hurt, and it may help. The other thing that I should say about an anti-inflammatory diet is that the way they're usually rolled out is with a strict elimination, where we take all of that stuff that we want to limit out for 6 to 8 weeks, and then we can slowly integrate the nutrients back in and see what it's doing with our pain or inflammation in our body. So it's not something that we can easily just give a handout and be done with it. That might be a good opportunity for you to refer to alternative healthcare providers or dietitians, and they can guide a patient through that process of elimination and then reintroduction. So it really depends, but a lot of times we're willing to try anything besides NSAIDs or remaining in pain.
Okay, one more question, and then I can't speak for all of you, but I'm starving.
Just one question about pineapple. It has bromelain.
Mm-hmm.
Can you compare that to the other things and how much you'd have to eat?
Right.
to-
So my main knowledge of bromelain is as a meat tenderizer. As far as its anti-inflammatory benefits, I'm really not versed on that, so I can't speak to it. But it does make your meats delicious. All right.
Thank you
Yeah,
so
thanks
much.
for your attention, everyone.
And